well-known saying that at any point of time there are more number of researchers and uh, gen- geneticists and doctors working on neuroblastoma than the number of patients of neuroblastoma that exists. So it's a very enigmatic disease. Uh, you know, from the point of view that you may have a 3 or 4 month old baby with um, disease, massive disease in the liver, skin, and his disease regresses on its own without any treatment. And you may have a child with a single bony metastasis and a adrenal mass, and he may not make it because the outcome of high risk neuroblastoma is quite poor. So from self regression to the extremes of treatment where we give chemotherapy, surgery, radiotherapy, autologous transplant, immunotherapy, and the whole gamut of pediatric oncology is applied into one disease, to a disease which can actually self regress without any treatment. And the biology is just amusing. And to get this straight in front of you, we have two very eminent speakers today, one a geneticist and one a pediatric oncologist. Both are consultants at Sir Gangaram Hospital, and it's my proud privilege to welcome Dr. Veronica Arora, who will be talking about the genetic aspect, and Dr. Divit Sachdeva, who will be talking about the clinical aspect of neuroblastoma. So over to you, Veronica, to start your presentation on genes in neuroblastoma, demystifying the genes in neuroblastoma. Thank you.
Can you also introduce Dr. Mukesh Thankar?
Actually, Dr. Mukesh does not need any introduction. He's the star of IAP Delhi. Mukesh is there everywhere in all the posters. He's the poster
Yeah.
boy for Delhi IAP. So welcome, Mukesh, and thanks for joining. And we will
Right,
wait
right.
for your comments throughout the session, and also your concluding remarks after both the talks. And if you could just summarize at the end as well. So thanks, Mukesh, for joining
Right,
in.
right. My pleasure. Okay.
Thank you, Dr. Manas, for the kind introduction, Anupam sir and Dr. Mukesh. So, I'd be talking about the genetic aspect and demystifying the genes, which I'm not sure really can be done. This is a bigger enigma for us as well. So, starting with neuroblastoma, we know that it is the most common tumor seen in the first year of life, and that's why so much research really on it. And it is the most frequent extracranial tumor of childhood, also. It is derived from the neural crest cells and may arise from adrenal medulla or anywhere along the paraspinal sympathetic ganglia. Typically, it presents with bone pain, anemia in smaller infants, hepatomegaly, and has a median age of diagnosis of around 1.5 years. While neuroblastoma accounts for approximately 5% of all cancer diagnoses in pediatrics, it disproportionately results in 9% of all childhood death from cancer. So, compared to other adult and pediatric malignancies, the neuroblastoma has a remarkable phenotypic heterogeneity, as Dr. Manas also elucidated too, ranging from a magical spontaneous regression with no treatment to relentless progressive disease, which is resistant to even multimodal therapy, which we have now for it. Approximately 40% of children diagnosed with the same are classified as high risk, and only 50% will achieve a long term survival. Conversely, patients with low and intermediate risk do well, achieving greater than 95% overall survival. One consequence of this phenotypic heterogeneity has been a considerable uh, effort placed on prognosticating the outcome at the time of diagnosis to ensure that treatment is optimally tailored. The International Neuroblastoma Risk Group classification uses 7 clinical and biological factors which grades them. The expectation of this non-surgical classification system is to allow for comparison of patient outcomes by risk groups across and maintaining really a uniformity of the same. So let's talk about familial neuroblastoma. Though the majorities of these tumors arise sporadically, rarely this cancer is heritable. But that we need to concentrate on those 2 to 3% cases as well, where we do have the hereditary component. In 1967, Shatton and Voorhees were the first to recognize the heritability in their description of a family with 4 out of 5 siblings who developed early onset neuroblastoma. Early additional case reports of families with an unusually high incidence of the disease were described subsequently. We now know that familial neuroblastoma occurs in 1 to 2% of neuroblastoma cases, and it tends to present at a younger age with a family history of relatives with the same tumor and an increased likelihood of multiple primary sites. So even though a lot of them may not be monogenic, where we can point towards a Mendelian autosomal dominant inheritance, but most of them will have some genetic basis, and you will tend to see familial clustering in these, not always in a dominant fashion. It is usually inherited and autosomal dominant with incomplete penetrance, similar to retinoblastoma, and confers to the classic two-hit hypothesis. That is, you are born with one variant in your blood, but the disease only occurs if there is a second variant or a second mutation in the tissue of concern. So this is the same as the two-hit hypothesis in the retinoblastoma. So every person who carries a mutation in the blood for in the genes causing neuroblastoma will not necessarily develop the disease. We need to have an additional mutation in the tissue for the disease to occur. Additionally, some family members harboring the predisposing genetic mutation do not develop neuroblastoma. Although familial neuroblastoma is rare, careful investigations of these cases has yielded important information on neuroblastoma tumorigenesis. So this is how an autosomal dominant pattern of inheritance looks like. So if we see that there is a mutation that is present in a person, as we can see here, it is described by a cross. So this mutation in one allele out of the 2 alleles present is enough to cause the disease. So all the children who inherit the mutation, that is the cross, will have the disease. But there is a caveat in case of cancers and neuroblastomas. The caveat remains that even if these children are inheriting this one mutation, they do additionally need a mutation in the tissue. Only then will they develop neuroblastomas. So there is not exactly a 50% risk of affection, though the risk of inheritance is 50%. So I hope that point is carried, that the risk of inheritance remain 50%, but the risk of affection is less than that. So a lifetime risk becomes lesser. So the risk factors, except genetics, also include opioid consumption, folate deficiency, exposure to alcohol, sex hormones, diuretics, hair color, electromagnetic waves, and congenital abnormalities like congenital syndromes like Down syndrome, leukemia, and urogenital and cardiac anomalies are also associated with the same. So genetic disorders also which are commonly described include Turner syndrome, Hirschsprung disease, and neurofibromatosis type 1. So Turner syndrome, we all know, is a syndrome of primary amenorrhea, short stature, and girls with XO genotypic component. And we have familial neuroblastoma, which includes 2% of the total neuroblastoma affection, and we will shortly discuss all the syndromes that can be a part of the same. So the pathogenesis involves the development of the tumor from residual microscopic neuroblastic nodules, and this has an origin from the extraadrenal neuroblastoma. So the extraadrenal neuroblastoma, when we talk about it, their origin is less studied and less known. And I think our experts can also throw light on the pathogenesis of the same. The main chromosomal and the genetic disorder misexpressed in the neuroblastoma include a chromosomal deletion of 1p, 11q, and 14p, and this constitutes about 50% of the genetics of neuroblastoma. So on the tissue, we carry out something known as chromosomal microarray, which will pick up these deletions, and thus we know the genetic basis of it. Also, we have a duplication or a overexpression of this oncogene, which is the NMYC gene, and it constitutes 25% of the cases, and a gain of chromosome 17q coming from the maternal side. This is supposed to be maternal, and this can also be characterized by your microarray or your fish studies. So a fish study is also an important, very quick test for neuroblastoma identification. And we also have alteration in the total DNA content, which may be lesser in some parts and much more in the others. So then we have expression of in some factors as well, like the BDNF and the NGF growth factors. So now these variants are to be checked in the tissue of interest. Here, the ones I have just mentioned are not the inheritable variants, and these are not the ones in which you can test the children or the fetuses for the same. These are the ones causing the disease in a sporadic person with neuroblastoma or a sporadic case in a family with neuroblastoma. So here's what we just discussed, that there is a mitotic dysfunction and a chromosomal aberration which causes much more increased expression of the neurogenic growth factors, which normally we need a number of 2n, and this number becomes 2n, 4n, with increase in expression of these chromosomes. So now genetic testing helps us by telling us that if we have these chromosomal aberration, we'll have a poorer prognosis, but if we don't have this, the prognosis is much better. So this NMYC amplification, a 17q duplication, leads towards a poorer prognosis. So genetic testing is helpful for us in prognostication of these individuals. So these are the common genetic disorders that as postgraduates in pediatrics, you need to remember, not just for neuroblastoma, but they are common disorders as well. But these are associated with your neuroblastoma. Number one is the congenital central hypoventilation syndrome. You will find these children often in the pediatric ICU presenting with respiratory dysfunction, autonomic dysfunction. You may see Hirschsprung disease and a neural crest tumors, because the origin of all of this is neurogenic, and the gene associated is FOX2B. The test of choice here will not be microarray, will not be NGS. We have a specific test for congenital central hypoventilation syndrome, which is known as a triplet repeat PCR, in which we look at the polyalanine and non-polyalanine repeat regions and look for expansion of some repeats. So if you're suspecting this and you have a neuroblastoma with respiratory dysfunction, we need to think of congenital central hypoventilation syndrome. Then we have other disorders in the rasopathy spectrum, including Rodad, Costello, Noonan, NF1. And whenever we have any of the patients with rasopathy, we need to look for neuroblastoma phenotype. Then Beckwith-Wiedemann syndrome, a baby with higher weight, diabetes, coarse facies, macrosomia, and associated Wilms and hepatoblastoma or neuroblastoma, we need to think of a Beckwith-Wiedemann syndrome. Leaf-Fromening caused by mutations in the guardian of the genome, that is the TP53 gene. The carriers of these mutations have a higher risk of developing neuroblastoma. Now we spoke, all of these are hereditary, all of the ones we spoke about were familial or hereditary, but of course the bigger scope even in genetics, is of a sporadic neuroblastoma. Important to remember that sporadic cases can also be genetic, because there is a difference between a familial and a genetic disorder. A familial disorder necessarily runs in the family, they are genetic, but a sporadic disorder occurs first time in an individual, but that also can be due to a genetic change. So now, although many cancers can be attributed to genetic changes induced by hereditary predisposition as described in neuroblastoma for the FOX2B and ALK gene, others may be a result of lifestyle or environmental factors, as I also just spoke about. However, these modifiable factors are now thought to account for only 1/3 of all cancers globally and are not known to be contributory to the development of neuroblastoma. That is, there is something in genetics that we are missing. Additionally, perplexing in neuroblastoma tumorigenicity is the fact that only a small subset of tumors have an identifiable oncogenic driven mutation. So we are still to look for the other driver mutations causing this disorder, and thus a lot of research remains to be done. Together, these findings raise the fundamental question of why some children develop neuroblastoma and what predisposing factor may be present in these patients. Due to inherent limitations of candidate genes and family association studies, the question could not be addressed until the development of genotyping arrays and high performance computing tools like genome wide association studies are done widespread in individuals. So finally, before concluding, I just want to throw some light about collaboration with therapeutic and technological advances, because we are all doing these genetic testing, number one, to assess the heritability component, and number two, and very importantly, to get to some therapy that is a little bit helpful for surgery in these cases as well. So, insights into the both familial and sporadic cases of neuroblastoma has led to an improved understanding of the fundamental biology that promotes neuroblastoma tumorigenesis. These discoveries continue to drive hypotheses for clinical translation and have generated avenues for targeted therapeutic development. For example, targeted therapies have been developed for ALK plus positive neuroblastomas, and others are in the development for many of these. In addition to the phase 3 trial evaluating crizotinib in the newly diagnosed patient, there is a recently closed phase 2 trial combining crizotinib with the upcoming chemotherapy also. Newer generation ALK inhibitors such as sedatinib and loratinib, which overcome resistance to crizotinib, are also under investigations. So I'm sure Dr. Divij will take you through more therapies. So my message here really is that in neuroblastoma, 3% would be inherited. You look at syndromic association, as I mentioned, and in the rest of them, we look at tumor testing by microarray and FISH. Thank you so much for your patient listening.
Thank you so much, Dr. Veronica, ma'am, for wonderfully summing up the genetics of neuroblastoma. And it's an intriguing disease, as Dr. Manas sir has already alluded about. So I am now going to talk a bit about the management, the approach to a child with a neuroblastoma. Actually, as a pediatrician, it is very important for you to pick up neuroblastoma, and how to go about the diagnosis of such a patient is what is important. I hope you can see my screen. Is my screen visible?
अपनी स्क्रीन से पहले ऑफ करना पड़ेगा, तभी आपका स्क्रीन शेयर स्टार्ट होगा.
Veronica ma'am, I'll just tell her to do it. Yeah, 1 minute. So you can all see my screen, is it?
Yes, sir.
1 minute, I'll just put it on slideshow. Yeah, So, my name is Dr. Divij. I am an associate consultant in pediatric hematology oncology in BMT at Sir Gangaram Hospital. So, we know that neuroblastoma, it is a very common pediatric tumor. It is actually the commonest extracranial solid tumor in children. Gliomas are the most commonest solid tumor in pediatrics. Now, it invariably accounts for somewhere around of 8 to 10% of childhood cancers, and especially it takes precedence in children less than 5 years of age. Most of the children, 90 to 95% of them, are going to be diagnosed by 10 years of age. And it's a clinically vague tumor, like we have already discussed about, that it can present in multitude of spectrum of diseases and prognostic classification. So if we look at the amount of incidence of all cancers, this is the SEER database from 2009 till 2012. Neuroblastoma accounted for around 6 to 7% of cases over here. Now, if we look at the incidence as far as the age is concerned, we see that neuroblastoma most commonly occurs in age groups of less than 5 years of age. So it's very atypical for you to have a child somewhere around 10, 12 years of age to present with a neuroblastoma. Although at Gangaram, we have seen a few cases that have presented at that age group as well. Now, it is clinically and biologically heterogeneous. You can have the low risk or very low risk cohort with infants just presenting with, asymptomatic abdominal distension, these kind of blueberry muffin skin lesions with skin manifestations in these children, and they can have a bit of, respiratory distress associated with the hepatomegaly that happens in this cohort of patients. Then you have the in-between group of patients, which are the intermediate risk patients. These are the ones that might require a bit of therapy. Low risk, very low risk are the ones that, either can go spontaneously regress, or they require minimal therapy. And then you have the, feared high-risk neuroblastoma with wide metastasis in an older child, and these typical raccoon eye presentation of neuroblastomas that can be there. These patients are the ones that are intensely refractory to therapy, and you have basically all arms of oncology taking care of such patients. So we know that ma'am has already talked about this, that the cell of origin is the neural crest cells, and because these neural crest cells go and migrate to the adrenal medulla, that is where catecholamines are synthesized. So neuroblastomas can secrete and store catecholamines, and it is seen in up to 80 to 90% of all tumors. So it's an intriguing malignancy because it can undergo spontaneous differentiation also, and it can also undergo differentiation with, some drugs that we are going to talk about. So this is your notochord, your neural tube, and then these outpouching from the ectoderm, the neural crest cells. If they're normally growing, they form the enterochromaffin cells and the sympathetic neuron and the sympathetic ganglion. But when they acquire mutations in MYC, FOX2A, Lin28B, anaplastic lymphoma kinase, that is when a neuroblastoma is derived from these cells. So normal fate is that it is going to form nerves and it is going to form the ganglions, but unfortunately in some patients it might aberrantly differentiate due to these acquired mutations, causing a neuroblastoma to develop. So this is your normal catecholamine metabolism, and the ones that are highlighted in red, dopamine, norepinephrine, these can be picked up in the serum in these patients. So once you have a child with neuroblastoma, it's very important to measure these catecholamine levels, because you're awaiting a biopsy for a child who's suspected to have a neuroblastoma. You can start empirical therapy, won't say it empirical, but you can start therapy before the biopsy report comes. If you have elevation of either the HVA and VMA in the urine, or the norepinephrine or dopamine in the serum in these patients. Now, ma'am has already said that less than 3% of cases are familial. Multiple genetic alterations have been identified. So you have your MYC status, your tumor cell ploidy, your segmental chromosomal abnormalities, and receptor tyrosine kinases. These are the ones that are of prognostic significance to these patients. Vis-a-vis your P53 destabilization, ALK mutation, and FOX2B mutations are more common in familial forms of neuroblastoma. Now, which is the most important prognostic significant genetic alteration in these patients? It is MYC amplification. So your MYC is a normal oncogene which is located on chromosome 2p24.3. Now, what happens in amplification is that there is a localized change in the gene, which increases the dosage of the genes or the subsequent pathways that are affected because of the gene. Now, approximately 20 to 25% of neuroblastomas are going to have MECAN amplifications. Now, MECAN makes everything worse. It is associated with more metastatic disease, inferior response to therapy, and resultantly higher relapse and refractory rates. Now, it is also associated with other inverse prognostic markers like segmental loss of chromosome 1p and TERC-B, which can upstage disease even if associated with other favorable characteristics. Now, this MECAN amplification is quantified by a copy number which can be detected by FISH. So if you are having more than 4 copies, it is associated with high-risk disease. However, the ones that are having a MECAN amplification of more than 10 copies are the ones that have the worst prognosis. Now, it can be detected by FISH. So if your NMIC is undergoing amplification on the chromosome only, you can detect it by these homogeneous staining regions on a FISH analysis, versus double minutes are extra chromosomal materials in these patients. So both of these patterns are regarded as a MECAN amplification, and obviously it confers a worse prognosis. So these are your FISH images. This is your homogeneous staining region in the chromosome, and these are extra chromosomal double minutes that can be picked up by FISH. Now, the other prognostic significant genetic marker is segmental chromosomal abnormalities. We know that we have 23 chromosomes which have same number of copies that are in any cell of our body. So normally our cell number is 2n. Okay. Now what happens is, when you are having a segmental chromosomal abnormality, you either have just a gain of one of the long or the short arm of one of the chromosomes. Now, certain gains and losses of these chromosomes are associated with bad prognostic markers. So one of them is loss of chromosome 1p, loss of 11q, and gain of 17q. So these are the segmental chromosomal abnormalities that are associated with inferior outcome as far as a neuroblastoma is concerned. Now, because if you are having a segmental chromosomal abnormality, you don't gain on your chromosome number. So your DNA index, which is the amount of DNA that is inside that particular cell, stays at a normal level. So a DNA index of 1, which is diploid, is associated with segmental chromosomal abnormalities and inverse prognosis. And the ones that are having a high DNA index are associated with numerical chromosomal abnormalities and better prognosis. So this was studied in around 900 patients by the Children's Oncology Group, and it was found that unbalanced 11q loss of heterozygosity and 1p36 loss of heterozygosity was associated with worse outcomes in patients with neuroblastoma. There are other segmental chromosomal abnormalities that also can be found in neuroblastoma patients, but they are not really associated with prognostic impact. Then comes into your familial neuroblastoma. Ma'am has already talked about it, so I'm not going to allude more about it. Just to tell you, FOX2B is a gene which is commonly implicated in familial neuroblastoma, but it is not associated in sporadic neuroblastomas. Ma'am has already talked about this. I just want to mention that these patients that are having neuroblastoma predisposing syndromes, they need to be monitored in your OPDs for with the ultrasonographic examination for the development of neuroblastomas or other cancers associated. So you have to have a high index of suspicion in these cases, and you don't just let them loose without proper monitoring. Now, sites of presentation, most of the patients are going to present with an abdominal disease. Around 60 to 70% of children are going to have an abdominal disease, with 50% of them having an adrenal location. Now, there can be other locations wherever the sympathetic ganglion is there. So you can have either your thorax or your neck being impinged with Horner syndrome kind of presentation. You can have your mediastinal mass in the neck. You can have a diffuse abdominal mass and seeding into the liver, into the nodes, or you can have a pelvic mass. And obviously metastatic disease is the one that is really feared about. It can be detected about to 50% of patients. And metastatic sites are usually the lymph nodes, the liver, the bone marrow. CNS is rare. It occurs only in around less than 5% of cases. Now, presentation, as I said, is dependent on the site of disease and age of presentation. Most of the infants that come with neuroblastoma, they have a biologically inert kind of neuroblastoma. It will go away with time, most of them. some do require therapy, which I'm going to talk about later. So most of them are going to present with abdominal distension or asymptomatic masses and blueberry muffin skin lesions, which I showed previously. Older children can present with locoregional disease or metastatic spread. And these children are usually sick with constitutional complaints like fever, decreased appetite, irritability. Pain is a predominant feature in these patients. So this is your child with a high-risk neuroblastoma. He can have associated signs and symptoms relating to the site. So your paraspinal tumor can also present with lower limb weakness associated with the neuroblastoma. Bone marrow metastasis, these patients are known to have severe pain, almost limping into the OPD and waking up in the night with diffuse pain in their limbs. It's a very sad scenario to see whenever you have such a patient. Then you have these celiac axis tumors, which can secrete VIP, causing secretory diarrhea. And then your adrenal tumors being the commonest presentation. So this is just a summary of the kinds of presentation that neuroblastoma can have. Now, neuroblastoma is intriguing because it can be associated with certain paraneoplastic syndromes also. So you can have your liver being studded with neuroblastoma, with the massive engorgement of the liver, with associated respiratory distress because the abdomen compartment pressures go up. So that syndrome is known as Pepper syndrome. We all know Horner syndrome is associated with ptosis, meiosis, and anhydrosis. Hutchinson syndrome is the marrow metastasis presenting with limping and irritability with bone marrow and bone metastasis. And the other syndromes I'm going to talk about. One more syndrome I want to lay light upon is the neurocrystopathy syndrome. Neurocrystopathy are club of neural crest disorders which usually occur due to that FOX2B mutation. They can have congenital central hypoventilation and Hirschsprung disease associated. Now, opsoclonus myoclonus ataxia syndrome is a rare but interesting presentation because it occurs very infrequently in neuroblastomas. It will be around 2 to 3% of cases of all neuroblastomas, but 60 to 70% of OMAS patients that are presenting to a neurologist or to a pediatric hematologist oncologist can harbor a neuroblastoma. So once you have a patient that is having opsoclonus myoclonus ataxia syndrome, a rapid search for a neuroblastoma should be done so as to ensue proper therapy for these patients. So they can present with involuntary bobbing movement of the eyes, rhythmic jerking of the limbs, and sometimes with ataxia. Now, the intriguing part of this is that they are biologically favorable and localized masses. So the neuroblastoma doesn't really trouble us. It's the OMAS that even after removal of the neuroblastoma and treatment with immunosuppression can be highly refractory. So we usually treat them with IVIG, steroids, ACTH, cyclophosphamide, or rituximab. The role of surgery is controversial in these patients. So this child presented to us 2 months back in the PICU, and this video you can see. So these are the characteristic saccadic movements of opsoclonus that you can see in the child, and involuntary movements in the limb of the patient. Now, we started immunosuppression for this child, and he's getting slowly better. The other intriguing presentation is the one with the celiac axis tumor with VIP secretions, which can present with intractable diarrhea and hypertension, again associated with a more differentiated subtype. And surgery can cause cessation of symptoms. You might require fluid and electrolyte replacement, and sometimes octreotide infusion to decrease the secretory diarrhea. Now, very interesting phenomena that congenital neuroblastomas and neuroblastomas in infancy are known to regress spontaneously. As a matter of fact, 2-3 months back, I had a case that presented to me in the OPD. This lady was pregnant. She was having an antenatally diagnosed neuroblastoma in the coming fetus. And, we've just told her to follow up post delivery of her baby. So they will probably come to our OPD, and we are going to follow it up with just sonographic imaging and measurement of the urinary catecholamines. So these patients are usually having a localized or 4S stage type of neuroblastoma. There's no role of newborn screening in patients with neuroblastoma. You don't, put a probe and look for neuroblastomas because they're known to spontaneously regress. And how do we know this? Because, US and Japan did conduct newborn screening for these patients, and then they found out that most of these patients that were having these antenatally diagnosed or infancy neuroblastomas, they were the ones that were spontaneously regressing. So it does not have a utility as far as neuroblastoma is concerned. Okay, next comes to question, how do you go about diagnosis of a neuroblastoma? So the lab evaluation, a normal CBC DLC should be done, and LDH and ESR should be done. LDH will give us the amount of tumor bulk, although it doesn't hold prognostic significance here. A PT-APTT should be done because liver seeding can cause coagulation derangements, and a LFT-RFT should be monitored. A basic chemical profile should be done. Urinary catecholamines are very important, like I have already alluded before. Now, the first modality of imaging is an ultrasonography, followed by CT MRI of chest, abdomen, and pelvis, usually at centers that are, primed in neuroblastoma care. We usually go with an ultrasonographic examination and do a biopsy under guidance and a PET CT to supplement it if you're not having the ability to do an MIBG scan. So both MIBG scan and PET CT are done for staging of these patients. And a biopsy and histopathology has to be sent for different kind of samples. You have your histopathology with immunohistochemistry in these patients. You have to do a marrow examination to see marrow seeding, and you have to do a FISH analysis for MICN amplification, and a microarray for segmental chromosomal abnormalities, and your flow cytometry can show your DNA index in these patients. Now, the first modality is USG. It is a solid heterogeneous mass. It helps in localizing the tumor. Now, it arises from adrenals in 60% of cases. The most important thing is that calcification can be visualized in USG. So if you're having an adrenal mass with calcification on an ultrasonogram, you can be fairly, concerned that the child is having a neuroblastoma. Now, neuroblastoma is it encases and displaces structures and doesn't infiltrate. So usually, if you're having a neuroblastoma, it's going to encase your critical vessels or your structures, but it won't directly infiltrate the structures. It usually crosses the midlines, and an ultrasonography can also help in detecting nodal metastasis. So this is an ultrasonograph which is showing these calcifications in this suprarenal mass. So this child went on to have a neuroblastoma. A CT and MRI can help in better anatomic localization of the lesions. Now, both imaging modalities have the definitive role. CT obviously has the issue of giving radiation, but it has better detection of calcification and has a rapid accrual. It's better for bony metastasis, and MRI is usually done for patients that are having a paraspinal tumor, that in cases with lower limb regrets. So this is your CT image of a child that presented to us in Gangaram. So you can see this is the abdominal aorta, and this patient, the lesion is encasing the abdominal aorta. You can see it over here also on the right side image as well. So it encases structures. And MIBG scan is a staging investigation, like I told before. Now, MIBG is an analog of norepinephrine. So it is taken up by the norepinephrine transporters inside the neuroblastoma tissue. Now, radio labeling is done with iodine 123, which can help in localizing the lesions. Now, it can also be coupled with a single photon emission computer tomography to increase the anatomic localization of these lesions. Now, 90% of tumors are MIBG avid, and now scores are drawn based on involvement of anatomical segments. So, an MIBG scan is graded based on skeletal segments from the top to bottom, and you have 9 skeletal segments. So your MIBG uptake is graded 1, 2, 3 based on the involvement of the segment. If you're just having like localized involvement, it is MIBG score 1. If you're having less than 50% of involvement but more diffuse, then you're having an MIBG score of 2. And then if you're having like more than 50% involvement of any segment, then it is scored as MIBG score 3. So total score of around 30 is given, and any soft tissue involvement is given 1 more extra score. Now, this has prognostic significance. After, you give induction chemotherapy to these patients, those that have a residual score of more than 2 are the ones that do worse off as compared to the ones that are having less than 2. Now, FDG PET is done when MIBG is non-conclusive or non-avid. Like at Gangaram, we don't have the facility of MIBG scan. So we stage our patients with PET CT. Now, it can also be used to assess response and better at detecting bony metastasis than MIBG. So this is another patient of neuroblastoma. You can see all those red areas. This is your liver has normal physiological uptake in these patients. So this is your neuroblastoma lesion. Again, this is more neuroblastoma lesion, and this is skull dissemination. This child did not have CNS dissemination, and on the right side you can see everything. All of these blacks except the epiphyseal plates are all disease sites for these patients. So this child ended up having a high risk neuroblastoma. Again, this is another case of neuroblastoma showing typical bony metastasis in this patient with neuroblastoma. Now, histopathology is the harbinger of therapy for neuroblastoma. We need to do histopath for most patients with neuroblastoma. It belongs to the small round blue cell family of tumors, which can have lymphomas, medulloblastomas, gliomas, even sarcoma, rhabdomyosarcoma, and retinoblastoma in the same family of tumors. Now, for us to characterize the histopathology, they are all classified according to the balance between the neural type cells, Schwannian stroma, and the neuroblastic cells. So you have on the lower end of the spectrum of a ganglioneuroma. A ganglioneuroma is a differentiated tumor. You have good amount of Schwannian stroma. So all of these spindle cells that you can see in the background, this is all Schwannian stroma. This is your ganglion cell, which is normally there in your nerve cells. So this is a slightly benign or completely benign variant of a neuroblastoma. Vis-a-vis, you have your slightly more aggressive subtype of a neuroblastoma, which is a ganglioneuroblastoma, where you can have these atypical cells in either foci inside or like an intermixed pattern, and you have this Schwannian stroma in the background. Versus this is your real, elephant in the room with neuroblastoma, having these small round blue cells with dense chromatin and highly aggressive nature. So these are your normal histopathology findings in a patient with neuroblastoma. So we know that neuroblastomas are the most aggressive, and they are also divided into undifferentiated, poorly differentiated, and differentiated variety. And then neuroblastomas can also be distinguished by IHC. So they normally take up IHC for neuron-specific enolis, synaptophysin, chromogranin, and S100. Now, for us to standardize treatment for neuroblastomas, we need to know standard histopathological grading for neuroblastoma. So the INPC was a histopathological grading that was developed in 1999. And nowadays, all centers that do proper oncology care denote their neuroblastic tissue reporting according to the INPC. So the ones that are having less than 50% of Schwannian stroma development, those are the ones that only have a neuroblastoma. You can have some aberrancy with some nodular ganglioneuroblastomas also presenting with less than 50%, but most of the neuroblastomas have less Schwannian stroma. And then, they are further divided based on your degree of differentiation into categories, and then you take into consideration the mitosis karyorrhexis index and the age of the patient to grade the child into favorable histology or unfavorable histology. So it's important to note that you can see on the lower end of the slide over here that patients that are having even poorly differentiated neuroblastomas but a lower age and a low MKI can also be characterized as favorable histology. So it takes into concern not only just the microscopic images, but the patient profile and the biological profile as well. So going to the staging of neuroblastoma, it also has gone through a sea of change from the 70s and 80s, where we used to use Ivan's system and Shimada system, to the late 80s, where the surgical staging criteria was developed. And now in the year 2005, we have the INRG, which denotes your staging for these patients. Now, the INSS was the previously used staging system. Just to sum it up, stage 1 is localized tumor, stage 2 is which has undergone stage 1 is localized tumor which has undergone gross surgical resection and no metastasis. Stage 2 is the one that has either undergone incomplete gross excision or you have nodal metastasis to the ipsilateral node. Stage 3 is unresectable tumors which have either metastasized to the opposite side with lymph nodal metastasis, or they are, completely infiltrating across the midline. And stage 4 are the metastatic tumors. A caution, or I would say a special variety of stage 4 patients is the stage 4S patients, in which you have localized primary tumors less than 1 year of age, which has been revised in the INRG. I'm going to talk about that, with limited metastasis to the skin, liver, or bone marrow. So the INRG is the current system, and we divide tumors into L1, L2, M, and MS. And the L1, the distinction between the localized tumor is the presence of image-defined risk factors, which I'm going to talk about. Metastatic tumors are the ones that are spread beyond the constraints of the original site. And MS tumors, you can see the distinction between the two staging systems. Previously, we used to consider children only less than 1 year of age as stage 4S, versus MS now has children less than 18 months also with marrow metastasis. So we've gotten to know that children less than 18 months of age do better as far as neuroblastoma is concerned. Now, what are these image-defined risk factors that upstage a patient from a localized disease of L1 category to L2 categories? Now, these are factors that are known to impair the likelihood of a safe surgical resection. So the IDRFs are either compression, if you're having an airway that is being compressed and you're having a reduction in short axis of the lumen, either encasement. Encasement means that a vessel is traversing to the tumor and there is more than 180-degree contact for an artery and no visible lumen for vein. And infiltration is for other vital structure other than vessels. And spinal cord involvement is when you have more than 1/3 involvement of the spinal canal by neuroblastic tissue. So if you're having only contact which is less than 50% or less than 180-degree contact with an artery, it is not an image defined risk factor. Vis-a-vis, if you're just having slightly flattening of a veins lumen, it is not an IDRF. But if you're having more than 180-degree contact or complete flattening of the lumen, it's considered an IDRF. So these are your typical IDRFs that you see in a patient with neuroblastoma. These are site specific, which I'm not going to talk about right now due to constraints of time. Now, the current risk grouping takes into consideration everything: age, histology, staging, MECAN amplification, segmental chromosomal abnormalities, DNA index, and your other genetic mutations that can occur in these patients. So it's a complete synergy between pathology, biology, age, and stage that decides our prognosis for neuroblastomas. Now, two risk groups are there. There's a COG risk group and there's a COPIN risk group, which health stratification in these patients. Not going to go into details. So this is your your COG risk grouping for tumors. So you can see that most of the children with L1 or localized tumors are either low risk. The ones that are high risk are the ones that are having MECAN amplification. So MECAN amplification makes everything worse. Similarly, the ones that have segmental chromosomal abnormalities on unfavorable histology are the ones that do worse. So this is your COG staging, and this is your INRG staging. So we all branch off from common root of neuroblastoma, but it can, go into multiple directions with different modalities to treat each and every subtype. So it's getting intensely complex in the risk stratification, but this is very important so as to, prevent over treatment on certain low risk cohorts and to give optimal therapy to high risk groups. So why is risk grouping important? Because most of the patients with low risk are going to have a benign course. Vis-a-vis intermediate risk are going to have a locally invasive, but most are cured. But high risk are the patients that are having metastatic dissemination and often fatal disease course. So you can see that low end and intermediate risk, we have been able to have very good outcomes of more than 80% in these patients. Vis-a-vis high risk has remained poor since time immemorial. So you have outcomes that are dismal for these patients, around 30 to 40% 5-year survival only. So the current methods of therapy for neuroblastoma take into consideration the whole gamut of pediatric oncology. You have the interplay of surgery and chemotherapy for low risk and intermediate risk patients, and your high risk patients requiring radiation, immunotherapy, differentiation therapy, and stem cell transplant as adjunct therapy for these patients. There are new targeted agents that are also being developed for neuroblastoma therapy, which is in the pipeline and shall soon be applicable for better cure of these patients. So the low risk patients are either undergo a surgical resection or they undergo observation only. Whereas your intermediate risk are the patients that do require a bit of chemotherapy and surgical resection, and your high risk patients require everything that is there in oncology. So going into the low risk cohort, infants less than 6 months with localized masses. So if you're having an infant that is less than 6 months with a slight adrenal mass which is less than 3 centimeters if it is solid, or it is less than 5 centimeters if it is cystic, these are the patients that we observe only. We don't do any therapy for these patients. We just call them with 2 weekly ultrasonographic examinations and urinary catecholamines, and they spontaneously disappear in these patients. Now, most other low risk patients are monitored either with surgery or wait and watch therapy, or with minimal chemotherapy if there is organ compromise due to the neuroblastoma. The intermediate risk cohort are either patients with more localized disease, higher age, or bad histology, but MECAN amplification is not there. So MECAN amplification will make everything high risk. Now, these patients require minimal chemotherapy, 2 to 8 cycles, with reassessment done every 2 cycles for surgical resectability. So we want to, minimize therapy. That's why we are, wanting to do every reassessment every 2 cycles, so that we can surgically remove these patients. Again, complete surgical removal is not warranted, because as I told before, that these patients can undergo spontaneous differentiation of these tumors. So even if you're having a bit of residual in these patients, you can let it be there inside in the body, and it will differentiate to a more differentiated phenotype. And some patients might require maintenance of 13 cis RA. Now, 13 cis RA, 13 cis retinoic acid, is the agent that is pharmacologically used to differentiate the tumor. So it was studied in the early 2000s that maintenance with 13 cis retinoic acid improves outcomes, especially with high risk neuroblastomas. Now, high risk neuroblastomas are most aggressive all subtypes. Outcomes are dismal despite advances in therapy, and any MECAN amplified tumor is considered to be high risk neuroblastoma. We can see that as the era has gone ahead, the outcome of high risk patients has remained dismal. So we usually use a combination of induction, consolidation, and post consolidation of therapy for these patients. Induction is by giving a multi-agent chemotherapy, a peripheral blood stem cell harvest, and surgical resection of the primary. Consolidation is with high dose chemotherapy and autologous bone marrow transplant and radiation. As post consolidation, these patients are put on the 13 cis retinoic acid, and then there is this anti GD2, which is a molecule that is present on your normal nerve tissues and your neuroblastoma tissues. So there is an agent known as dinutuximab, which is cost restrictive. We are not able to give anti GD2 to most of our patients, because one full course of anti GD2 will cost somewhere around 60 to 65 lakhs for a child around 10 to 15 kg of weight. Given it to one patient, unfortunately, that patient also progressed on the neuroblastoma. So why do we have this design of therapy for neuroblastomas? Is because after giving induction therapy, after some time you have acquired drug resistance to the chemotherapy agent. So once you do a surgery, you further reduce the bulk of the tumor. Then whatever remaining bulk is there for after surgery is treated with an autologous transplant, and then radiotherapy helps consolidating that remission, and then maintenance therapy helps keep the enemy down. So this is how we treat high risk neuroblastoma. So this is like a whole protocol for treatment of neuroblastoma. This is your COPL protocol for neuroblastoma. So not going to go into the details. Despite this, the outcomes have remained dismal, like I have talked about. The future is that there are multiple targeted therapies that are being used for these patients that are in the pipeline. Sorry for the typo in the first word. There are aurora kinase inhibitors that are there. There's a difluoromethyl ornithine that is there. There's a therapeutic MIBG therapy, the same MIBG that was used to stage these patients, which can be used along with an autologous transplant. There are certain CAR T cell therapies that are under pipeline. There are other targeted inhibitors like MEK inhibitors and ALK inhibitors that are being used for these patients. Now, to conclude my talk, neuroblastoma is a common pediatric malignancy which affects children less than 5 years of age. Presentation can be vague, and it can be localized with asymptomatic disease to widespread metastatic disease. The decision to treat is dependent on histology, age, biology, and stage of the patient. There's potential over-treatment of low-risk and very low-risk group and need of urgent research and advancement in therapy for high-risk patients. Also, there are exciting new therapies on the horizon. Thank you so much.
Wonderful presentation, Dr. Divij.
Thank you so much, sir.
Even I learned a lot. So can we just see if we have any questions and answers from any of our audience?
So I think there was a question directed to Veronica ma'am, which was
You can take up that.
yeah, how to see for mutation in fetus prenatally in tissue of fetus, as one of my patient had retinoblastoma.
Hi. Hi, good evening. So, for neuroblastoma, if one of your patient has it, the primary diagnosis needs to be done on the patient. First, you need to perform the genetic test on the patient, and if you find a hereditary component, only then you can check the same mutation in the fetal tissue, be it an amniotic fluid or a chorionic villus sample. But first and foremost, we identify the heritable mutation and then test the fetus.
Okay, that's great.
Another question, I think.
Yeah.
I think she's just described the patient that she had. She's blind. She has given history that her vision is lost due to fever in childhood, but her first baby had trilateral retinoblastoma diagnosed postnatally, expired at age of 2 years, and the NGS shows retinoblastoma. In second pregnancy, amniocentesis showed retinoblastoma terminated at 16 weeks of age. So
Okay.
it is described the patient. Yeah.
Okay.
Any more questions as far as the attendees or the panelists are concerned?
I don't have any questions.
Thank you so much, Dr. Mukesh sir, Dr. Manas sir, Dr. Anupam sir, and Veronica ma'am for the wonderful session. And I hope we could shed some light on the genetics and therapeutics of neuroblastoma.
Definitely, it was definitely enriching for all of us.
Thank you.
It is wonderful to hear from Divij once again. Thank you, Dr. Divij. Thank you.
Thank you so much, Veronica ma'am. Thank you.
Thank you. And good night, everybody.
Good night.